Hi, this is Ron Berkman. This is the second part of our brief video lectures on shoulder dystocia. This part deals with documentation and approaches to reduce injury and litigation risk. If we look at how we document a shoulder dystocia complication, it's important that you understand there are a number of key elements that must be utilized. If you have trouble remembering a lot of this, there are a number of checkoff forms that are available through ACOG and through various publications that will list many of these. Clearly, you should list what risk factors may have been present that would lead to the shoulder dystocia. This would include estimating the fetal weight, whether or not the patient had diabetes. If oxytocin was used or an operative delivery was carried out, clearly the indications should be stated and be justifiable. One should list the duration of stages of labor, particularly the first and second stage. Obviously, one would indicate what the maneuvers were, which maneuvers were employed and in which order. And very importantly, which shoulder was anterior. This is often left out. And again, if there's concern whether this was a posterior shoulder impaction, if you don't declare which one was anterior versus posterior, it's difficult to justify this at a later date. Timing of maneuvers is helpful. In particular, the head to body delivery time is probably the most important. Obviously, if there is evidence of injury or at least weakness of one arm, the status of the infant should be at least discussed briefly in the initial documentation. Also, you should indicate which physicians or midwives or nurses as well as family members were attending the delivery, so that at a later date, for example, someone may state, well, I was there, when in fact they were not there, and this obviously could be problematic if documentation is not available. Finally, when these deliveries occur, it's important to document that one held a discussion of the delivery with a patient and her family, and document what was the nature of the discussion. It's important, I think, to avoid charting during the actual emergency. Certainly one can keep track of the time, that is one of the nurses who happens to be in the room, and maybe a few notes, but do not record in the chart. After the delivery, however, as part of your debriefing, certainly the steps and times and when they occurred should be discussed among the delivery team present, to ensure that there is consistency in subsequent notes. Avoiding adjectives, I think, is probably useful in that it really is not terribly helpful to say that gentle traction was utilized, in that perhaps, obviously, the family may not believe you if an injury occurs. Do document, however, that the shoulder dystocia management was life-saving, and that if it hadn't been carried out, the baby obviously was in substantial danger. Again, I emphasize that the estimated fetal weight should be documented, and certainly if there is any discrepancy, for example, between an ultrasound estimate and the estimated fetal weight clinically, that needs to be addressed. With a history of prior shoulder dystocia or in the presence of risk factors such as diabetes or macrosomia, it's important to document the informed consent process, particularly if vaginal delivery is contemplated. Those discussions should be held with the patient, ideally prior to labor, so that, again, if they are desirous of a vaginal delivery, that the facts are laid out to them, so that it is not done at an inopportune time when the patient is exceedingly uncomfortable during the labor process. If an operative vaginal delivery is performed, again, needs to emphasize that the indications should be well documented and defensible, and certainly the note should include the estimated fetal weight along with the station and the position. With a prior severe shoulder dystocia, documentation should also be there that suggests that the elective cesarean section perhaps was offered to this patient. Certainly most of us would do this, but I think documentation needs to be there, particularly if the patient elects to undergo a vaginal delivery. When, in particular, an injury has occurred, family discussions need to be coordinated with the pediatrician so that basically the same information is being given by the obstetrician or midwife as well as the pediatrician. It's important to emphasize the emergency nature of the event and the likelihood of improvement over time if a neonatal brachial plexus palsy occurs. Certainly, you would review what went on immediately, but I think it's also important to go back at a later time because families usually need time to process all the information, particularly if there have been a lot of people that have come into the room during the delivery and all of a sudden everyone leaves and they're not really certain what all went on and why it occurred. If there is evidence of a likely brachial plexus palsy, risk management should be involved early in the process in all cases, or particularly if problems with patient and family communication appear to be occurring. So what are the strategies to improve your defensibility of a potential medical legal case? And you can look at this as being important because most of us are aware that the cost of liability insurance has gone up, particularly in certain locales, such that many people have given up obstetrics because of this concern. That's unfortunate because the people giving up obstetrics many times are the most experienced. And I think there are ways that we can certainly improve our performance in managing this complication. Obviously, one of the best strategies to employ would be to prevent it in the first place. Then obviously you can improve management, and I think communication is also a very important aspect of how you deal with families and patients who have had this complication and a baby who has an injury. From the standpoint of prevention, these are some of the approaches that are supported by the recent neonatal brachial plexus palsy task force. One can consider the use of cesarean section if one suspects macrosomia greater than 4,500 grams in a diabetic patient, or if one suspects macrosomia greater than 5,000 grams in a non-diabetic patient. As noted in the prior video, most of this is not supported with crisp literature, but certainly it's a reasonable suggestion. Certainly women with prior severe shoulder dystocia, one cesarean delivery can be offered to them. In addition, if one is contemplating a mid-pelvic operative vaginal delivery in the presence of an estimated fetal weight of greater than 4,000 grams, I think most operators need to reconsider that and perhaps also offer the possibility of a cesarean delivery. Improving management is certainly an important aspect of all of this, and this is done through training, which can be didactic, or the use of simulation that includes the basic maneuvers, teamwork, documentation, communication, and certainly the use of debriefing after any episodes where a shoulder dystocia has occurred is important to identify areas where one can improve the management, and also to identify particularly process problems in the management of this complication. From the standpoint of didactics, certainly lectures such as this one, or the use of CD-ROMs that discuss the shoulder dystocia can be utilized as part of the training component. Simulation, I think, is a very good approach. You can use basic low fidelity mannequins or more highly sophisticated mannequins. I'm a strong supporter of in situ simulations where the actual simulation is carried out on the labor delivery unit. This allows more individuals who, again, would deal with this complication to participate, and also allow one to develop strategies to basically improve the overall performance and correct potential problems in managing the complication. Use of post-tests after a didactic lecture or after simulation both evaluates a program, but I think overall will increase the stakes for the participant. And some institutions will incorporate some of this training as components for credentialing or re-credentialing of individuals who do deliveries in their facility. Here's an example of a fairly low fidelity setup where the person is holding the fetus until it's delivered, and you can see the head protruding through the bottom. Certainly, when you do some of these simulations, a lot of things can be discovered. A group out of Bristol in the United Kingdom has certainly been pioneers in this particular area. In one of their studies, they videotaped over 400 simulations where there were close to 150 physicians and midwives involved. Before any training beyond the initial part of taping the simulation, about 57% were unable to deliver the baby, and this would mean progressing all the way to posterior arm delivery or having the baby delivered by 5 minutes. About 2/3 failed to call for pediatric support, even though they were having difficulty delivering this fetus in the simulation, and 4% actually used fundo rather than suprapubic pressure. They noted during their review of these 450 simulations poor communication among the team members. There was inability to gain internal access, for example, when doing a posterior arm delivery, because the individuals would not cup their hands. There was confusion how to do some of these. And in about 10-11%, clearly excessive force was being utilized. When they looked at, again, the use of simulation to train individuals, and this is another study involving over 120 physicians and midwives, they noted that pre-training, about half could not affect delivery, but after training and then examining the participants at 3 weeks, 6 months, and 12 months after training, clearly there was retention in their skills. The group that, in fact, showed problems at 3 weeks and were not able to demonstrate persistence of skills, when they were retrained at 3 weeks, their skills, you can see, improved, so that somewhere between 60 and 80% of them were able to affect a delivery when retested. What about the results from the standpoint on actual patients? And in this study, again from the group in Bristol in the United Kingdom, they looked at pre-training and post-training results. And all physicians and all midwives who did obstetrics were required to undergo a one-day emergency course, which included, as listed in the last bullet, approaches to deal with shoulder dystocia. The number of deliveries pre-training were somewhat higher than post-training. The rates of shoulder dystocia, however, were the same. Interestingly enough, they documented in almost 17% of shoulder dystocia cases excessive traction in the pre-training period, and in about 9% in the post-training period, which is, I think, somewhat interesting. But as the training had occurred, you can see in the far right column that the use of maneuvers that we utilize and others utilize, such as McRoberts, suprapubic, internal rotations, posterior arm delivery, clearly increased in utilization after the training episodes had occurred. And importantly, when they examined the frequency of brachial plexus injury, you can see that there was basically about a threefold reduction of the diagnosis of brachial plexus injury at the time of birth. And you can see that certainly the trend of more permanent or more persistent injury also occurred, though again these were not statistically significant results. From the standpoint of communication, our last area, again, risk discussions should occur prior to labor, as we've already emphasized, and these are individuals who have macrosomia, particularly macrosomia with diabetes and prior shoulder dystocia. You should discuss the events that occurred immediately after it occurs and at a later time, being factual and coordinated with a pediatrician. So in summary, in these two short videos, we've tried to point out that shoulder dystocia is somewhat unpredictable and can be challenging. The knowledge of and appropriate use of the various maneuvers is important, as is teamwork. And I think appropriate documentation, communication, and training are essential components of the management.